Hello everyone. The topic for today's discussion is leprosy. We are going to cover skin biopsies in leprosy. As you all know, leprosy is caused by Mycobacterium leprae and it predominantly affects skin and peripheral nerves. The sequence of disease pathogenesis is complex and it depends on the host parasite immunologic responses. So, immunopathologic spectrum is seen in leprosy. Tuberculoid leprosy indicates a high cellular immune response, that is T cells and macrophage activation, with few bacilli in tissues. The lepromatous leprosy, it indicates the absent cellular immune response to Mycobacterium lepra antigens with no macrophage activation and abundant bacilli in the tissues. Spectrum of leprosy is continuum and patient may move in either direction. According to host response and treatment. So, it is categorized as TT, tuberculoid leprosy, borderline tuberculoid, mid-borderline, borderline lepromatous and lepromatous. The borderline denotes patterns showing features of both tuberculoid and lepromatous leprosy. The indeterminate leprosy describes patients presenting with very early lesions that cannot be categorized definitely along the immunopathologic spectrum. So, staining of Mycobacterium lepra bacilli, it is done by modified Ziehl-Neelsen stain, White method and methenamine silver stains. The standard enumeration of leprosy bacilli lesions is known as bacterial index. So, bacterial index, according to Ridley's logarithm scale, it is divided into 0, 1 or graded as 0, 1, 2, 3, 4, 5, 6. 0, no bacilli observed. If 1 to 10 bacilli in 10 to 100 hyperfield is seen, then 2. 1 to 10 in 1 to 10 hyperfield, BI is 2. If 1 to 10 bacilli per hyperfield is seen, then BI 3. 10 to 100, 4. 100 to 1000 bacilli are seen per hyperfield, then 5. And more than 1000 bacilli per hyperfield, BI 6. For lesions where bacilli are scanty, it is recommended that at least 6 sections to be examined before declaring it negative. Solid staining bacilli indicates the organism is capable of multiplication. Fragmented or beaded and granular acid-fast bacilli, they indicate dead organism. Paucicellular lesions are in which patients with no bacilli detectable in lesions, and multibacillary, those with some or many bacilli, they are multibacillary lesions. Now we study the spectrum wise. First is early or indeterminate leprosy. In this, one or few hypopigmented macules are seen with variable loss of sensation. Any part of the body may be affected. On histopathology, there is seen only mild lymphocytic and macrophage accumulation around the superficial or deep dermal vessels, around neurovascular bundles, around sweat glands or erector pili muscles. Focal lymphocytic invasion into the lower epidermis may be seen. Schwann cell hyperplasia may be noted, but no epithelioid cell granuloma formation is seen. On AFB, 1 or 2 AFB in the site of predilection is seen. Then LL or lepromatous leprosy. The lesions are numerous in LL and they are symmetrically arranged. Lesions may be cutaneous or mucosal lesions. Lepromatous leprosy is divided into 3 clinical types: macular type, infiltrative nodular and diffuse type. In macular type, patient presents with hypopigmented or erythematous macules. In infiltrative nodules, there is seen nodules, involvement of eyebrows and forehead with loss of eyebrows and eyelashes. It is seen in infiltrative nodular type and the faces are known as leonine faces. Nerve most commonly involved are ulnar, radial and common peroneal nerve. The third clinical type is also known as Lucio leprosy, and in this infiltration of skin is present but without nodules. On histopathology, in LL, extensive cellular infiltrate is seen in the dermis, macrophages and plasma cells. There is extensive cellular infiltrate in the dermis, macrophages and plasma cells. Flattened epidermis is seen. Grand zone of normal collagen is seen between the epidermis and dermis. Infiltrate may cause destruction of cutaneous appendages, and extend into the subcutis. Infiltration is seen in the subcutis also, deeper dermis and subcutis. So basically there is abundant macrophage accumulation. In florid early lesions, macrophages have abundant eosinophilic cytoplasm and contain mixed population of solid and fragmented bacilli with bacterial index 4 or 5. No macrophage activation is seen, and lymphocytic infiltrate is not prominent, but there may be many plasma cells. In time with mycobacterial therapy, degenerated bacilli, they accumulate in the macrophages. So in early, solid and fragmented bacilli are accumulated, then degenerated bacilli, they accumulate in the macrophage. They are known as Lepra cells or Lucio cells. They have foamy or vacuolated cytoplasm. They resemble xanthoma cells. Waite-White stain, bacilli are fragmented or granular and disposed in large basophilic clumps known as globi. This is also a microphotograph showing Lepromatous leprosy. In this, you can see macrophage accumulation in the subcutis, foamy macrophages. Then histioid leprosy. Highest loads of bacilli are seen in histioid leprosy with BI 6, solid staining and arranged in clumps. Macrophage reaction is unusual in histioid leprosy, that is, they become spindle shaped and oriented in storiform pattern similar to fibrohistiocytoma. So they resemble fibrohistiocytoma. Epidermis may be stretched over such dermal expansile nodules. Then borderline Lepromatous leprosy. In borderline Lepromatous leprosy, less numerous lesions are seen and they are less symmetrical than LL. They have central dimples in lesions. On histopathology, lymphocytes are more prominent as compared to LL. In that case, plasma cells are prominent. In BL, lymphocytes are prominent and there is tendency for some activation of macrophages, but poorly or moderately defined granulomas. Perineural fibroblast proliferation is seen forming onion skin in cross section. BI is 4 to 5. Foam cells are also not prominent. So lymphocytes are prominent along with some activation of macrophages. Then mid-borderline leprosy or BB. Skin lesions are irregularly dispersed and shaped erythematous plaques with punched out centers. Satellite lesions, small satellite lesions may be seen. On histopathology, macrophages, they are uniformly activated to epithelioid cells. So epithelioid cells are present but not focalized into distinct granulomas. So distinct granulomas are not present, but scattered epithelioid cells are seen. Scattered epithelioid cells but no well-formed granulomas and no Langerhans giant cells. No granulomas and no giant cells, but epithelioid cells are present. Dermal edema is prominent. So microphotograph of mid-borderline. Macrophages are uniformly activated to epithelioid cells, but no well-formed granulomas are seen. Lymphocytes are scanty. No Langerhans giant cells are present. Then borderline tuberculoid leprosy. Lesions are symmetrical and may be scanty. Dry hairless plaques with central hypopigmentation. Nerve enlargement is usually found and lesions are anesthetic. On histopathology, granulomas with peripheral lymphocytes follow the neurovascular bundles and infiltrate sweat glands and erector pili muscles. So the important point is granulomas, well-formed granulomas with peripheral lymphocytes with presence of Langerhans giant cells. They are variable in number, but they are not large in size. Granulomas along the superficial vascular plexus, they are frequent, but they do not infiltrate into the epidermis. So granulomas are seen in the dermis. They do not infiltrate in the epidermis. Nerve erosions and obliterations is typical. Scant AFB is seen with BI 0 to 2. So the microphotograph of borderline tuberculoid leprosy. In this you can see granuloma formation with Langhans giant cell. Granulomas with peripheral lymphocytes and giant cells. Follow the neurovascular bundles, sweat glands. The next is tuberculoid leprosy. The skin lesions in tuberculoid leprosy, they are scanty, dry, erythematous and hypopigmented papules or macules with sharply defined edges. Anesthesia is prominent except on face, that is seen in LL. Number of lesions may be 1 to 5. Thickened local peripheral nerves may be found and lesion heal rapidly on chemotherapy. On histopathology of TT, as patient immune response is better, so large epithelioid cells arranged in compact granulomas are seen with dense peripheral lymphocytic infiltration along with neurovascular bundles. Langhans giant cells, they are absent. So Langhans giant cells were present in borderline tuberculoid leprosy while they are absent in tuberculoid leprosy. Absent in TT, present in BT, while granulomas are seen in both BT and TT. Dermal nerve may be absent or obliterated or surrounded by and eroded by the dense lymphocytic cuffs. AFB, they are rarely found even in nerves. This microphotograph is showing the destruction of the nerve by the epithelioid cells and lymphocytes. Coming to the leprosy reactions, there are two main types of leprosy reaction, type 1 and type 2, but third type is also present, Lucio reaction, specific to Lucio multibacillary leprosy. So type 1 reactions, because the immunopathologic spectrum of leprosy is a continuum, patient may move along it in both directions. Shift towards tuberculoid pole is known as upgrading or reversal reaction, and shift towards lepromatous pole is downgrading reaction. BB patients are more stable, BB patients are most unstable patient and will move either way depending on therapy. Pathology, typical, there is edema within and about the granulomas and proliferation of fibroblasts. In upgrading reaction, granulomas become more epithelioid and activated. Langhans giant cells are present and they are larger. May be erosion of granulomas into the lower epidermis. So granuloma may erode the lower epidermis and there may be seen fibrinoid necrosis within the granulomas. So granulomas become more epithelioid, giant cells are larger, they may erode the lower epidermis and fibrinoid necrosis is seen within the granulomas. In downgrading, necrosis is less common and density of bacilli increases. To Lepra reaction or erythema nodosum leprosum. Erythema nodosum leprosum. It is most common in LL but less frequent in BL. Seen in patients with under treatment and untreated patients. Skin lesions, they are tender, red plaques and nodules. Eruption is widespread and accompanied by fever, malaise, arthralgia and leukocytosis. Pathology, foci of acute inflammation superimposed on chronic multibacillary leprosy is seen. Neutrophils may be scanty or abundant, forming dermal abscess. Foamy macrophages containing fragmented bacilli are seen. Necrotizing vasculitis is noted, affecting the arterioles, venules and capillaries. So foci of acute inflammation, scattered neutrophils along with chronic inflammatory cells, they are seen. Now the Lucio reaction. It is seen in diffuse lepromatous leprosy when there is no treatment or inadequate treatment. Fever, tenderness and leukocytosis, it is absent in contrast to the erythema nodosum leprosum. Histopathology, endothelial proliferation is seen leading to luminal obliteration. Thrombosis in medium-sized vessels of the dermis and subcutis is noted. Sparse mononuclear infiltrate is C. AFB dense aggregate